Ross. Please go ahead. Thanks very much.
Thanks very much for that. So our title for our case was Somewhere Over the Rainbow Investigations. It was a survey on attitudes towards pre-operative investigations in the University Teaching Hospital. So we conducted a review on the current practice of ordering pre-operative investigations in our hospital and discovered that a significant amount of non-essential or unnecessary investigations are being booked. Not only does this incur a substantial cost and demand and of significant resources, but it may also cause potential harm to patients. Therefore, we assess the attitudes of the practitioners booking pre-operative investigations compared to the recommendations set by the NICE pre-operative investigations guidelines. An anonymized questionnaire was distributed to the intern cohort in our hospital and examining the driving forces of why they're booking investigations and the indications that they are using to warrant booking these investigations. The intern cohort was selected as they are found to be the most prevalent for booking investigations for elective surgery. The questionnaire was distributed on 2 separate occasions over a 6-month period with a total of 56 responses being received. Of the 56 interns' questions, 75% were not aware of any pre-operative investigation guidelines at all. 96% have felt under pressure to book an investigation, and 78% of participants have been scrutinized or penalized for not booking an investigation at a certain point. Main influence for booking investigations was consultant team preference at 69.6%, with other indicators being colleagues' advice at 10% and patients' ASA at 10% as well. Over 50% of those questions would book a complete screen, which included FBC, a UNE, a COAG, a CRP, an ECG, and a chest X-ray for all patients, regardless of ASA and regardless of the grade of the surgery. There was also a wide variance in reasoning for chest X-rays and echoes, with 16 and 17 different indications recorded for each respectively. 98% of participants felt that the introduction of preoperative guidelines would be beneficial for them in their daily lives. As opposed to the focused investigations that enhance our preoperative care, we have instead used a blunderbuss or a rainbow approach to testing. This has led to an increased demands on precious resources, as well as increased costs and potentially exposing us to future medical legal issues which have been brought up in the Medical Protection Services case reports. Risk of booking investigations without ensuring proper follow-up was also discussed in 2 sessions of teaching that we had with the interns at 2 separate occasions. Currently, pre-operative investigation guidelines are being introduced and their effect will be reviewed as we get through them. So that's my talk. Thanks very much for listening.
Brilliant. Thank you very much. And thank you for being so disciplined on the timing. So I'm going to start, if it's okay, with a couple of questions about the information you presented. So that when you say consultant preference, is that anesthesia consultant or surgery consultant or a bit of both?
So that is basically the surgical consultant. So the team goes off, the intern will go off what their consultant wants more so than, as I said, looking at the general hospital practice, looking at guidelines, or looking at surgical grade or the patient's ASA. So 39 of the 56 said that they've used that as their first preference to booking investigations.
And did you get any indication as to how much different specialties are working together to define what? Because I mean, so you hear quite a lot that surgeons will book a lot of tests because what they don't want is anaesthetists to cancel patients because they haven't thought of the tests that they might want. So to avoid anticipating, they just booked a whole lot. Did you get any evidence that there had been discussions between anaesthetic and surgical colleagues about the right level of testing for each patient?
So as we were doing the teaching session with the interns, we know that there was very little communication between anaesthetics and the surgeons at all regarding pre-operative investigations and when to book and what to book. As I said, we kind of went through the NICE guidelines with them to explain that, and also explain the risks of booking investigations. And as I said, we had a meeting with the surgeons to try establish some single site-based guidelines to try introduce that. Dedicated investigation guidelines for all surgeries. There were some specific surgeries that would require chest X-ray, such as the breast team wanted chest X-rays for all patients, regardless of ASA or that, even if they weren't recommended. I suppose. Oh, sorry.
Understood. And the patients that you included, are they all inpatient surgery, and were they low risk or moderate risk or high risk, or a mix of those groups?
So we included all patients who came in for elective surgery. So that included multiple cases of cardiothoracic vascular, as well as small surgeries like local excisions of tissues or inguinal hernia repairs, laparoscopies, those sort of things. But we had a general broad range. We have multiple disciplinary teams in our hospital, so we covered it a lot, I feel.
Sure. Any questions from others on the call? Okay, and where do you think you're going to go next with this?
So as I said in a follow-up talk that I have coming up next, we looked at the data of patients who came in. So we looked at patients who have in elective surgeries, we looked at the investigations that were booked for them, as well as going from there as what the results were and how they affected the perioperative management. But as I said, we're planning to continue our teaching sessions with the interns about, as I said, the dangers of booking too many investigations, as well as guidelines for introducing it, as well as introducing single site-based guidelines for the hospital that we're currently working in.
And I guess there is a balance, because the lower risk surgeries may need almost nothing, but at the same time, we're you know, more generally, we're talking about more detailed risk evaluation in high risk patients. So the response, I guess, needs to be calibrated depending on which type of patient.
That's exactly it.
Excellent. Thank you very much.
Thanks very much.
That's your time up, I'm afraid. Can I just check that you can all see a single slide projected, or can you see two slides?
Single slide.
Single slide. Brilliant. Okay, I will progress. Next up is Dr. Boylan.
Good morning, everyone. I'm going to present a rare case of drug-induced immune hemolytic anemia secondary to cefuroxime. Autoimmune hemolytic anemia is characterized by increased erythrocyte destruction in the presence of autoantibodies. Drug-induced immune hemolytic anemia occurs when the underlying cause of autoimmune hemolytic anemia is secondary to medication administration. Over 130 medications have been implicated in drug-induced immune hemolytic anemia. So this is a case of a 67-year-old female who was admitted electively for repair of a right quadriceps tendon repair, and this was attributed to a recent resurfacing procedure. Her background history was notable for type 2 diabetes, obesity, previous bilateral total hip replacements, bilateral total knee replacements, previous history of PE, and alcohol mixed-use syndrome. Her hemoglobin before surgery was 10 grams per deciliter. Renal function was in the normal range. She received a spinal anesthesia prior to surgery and was administered propofol and 1.5 grams cefuroxime at induction. The surgery itself was uneventful. 3 further doses of cefuroxime 1.5 grams were administered to this patient on the ward postoperatively. It is worth noting that this patient had received cefuroxime for her previous surgeries. The following day, our patient's hemoglobin dropped to 9.7 grams per deciliter. She received 1 unit of blood. 2 days postoperatively, her hemoglobin fell again to 7.1, despite receiving a unit of blood. This plummeted again on the same day to 5.5, and she received a further unit of blood. There was no evidence of active bleeding from the surgical site. 3 days postoperatively, our patient developed nausea, profound jaundice, sclera icterus, and oliguria, with an input of 5 litres of fluids and a urine output of 450 mL over 24 hours. Her urine was noted to be dark in colour. Her creatinine had soared to 547 micromoles per litre. She had severe metabolic acidosis. She was transferred to ICU for supportive care. Here, her hemoglobin continued to trend downwards to 5.2 grams per deciliter and subsequently decreased to 4.8. She was administered 4 units of blood, and her peak hemoglobin was again 4.8 grams per deciliter. Her liver blood tests were deranged, and her bilirubin was climbed to 239 micromoles per litre. Our differential diagnosis at this stage included compartment syndrome in our patient's right thigh, secondary to coagulopathy of liver impairment and profound hemolytic anemia. A Coombs direct antiglobulin test was performed and was positive for intravascular serum hemolysis with immunoglobulin, IgM, and complement C3d postoperatively. Her Coombs test was negative preoperatively. Blood film analysis revealed polychromasia, ferrocytes, nucleated red cells, and red cell agglutination. Our patient had drug-induced immune hemolytic anemia secondary to cefuroxime. In ICU, our patient was administered 200 IV hydrocortisone and IVIG Hemoglobin steadily rose to 8.3 and then to 9. Acute renal failure, secondary to pigment-induced acute tubular necrosis, resolved. The dramatic hyperbilirubinemia resolved as liver blood tests returned to baseline. Our patient continued to improve clinically and was discharged home. The incidence of drug-induced immune hemolytic anemia is about 1 in a million. Second and third generation cephalosporin are the most commonly described causes of drug-induced immune hemolytic anemia. Hemolytic anemia with ceftriaxone is well described. However, there are very few case reports of cefuroxime being implicated. Currently, there are no guidelines to confirm the diagnosis of drug-induced immune hemolytic anemia. The temporal relationship in our patient was clear, and our patient improved hemodynamically following drug cessation. This patient has been advised that she should not receive cefuroxime for further future surgical prophylaxis.
Thank you very much. That's a beautiful description of, clinical description of hemolytic anemia. How confident can you be that the precipitating drug was cefuroxime and not possibly another drug that was administered around the time of surgery and anaesthesia?
Well, I suppose what we did at the time was we had a list of all her medications and we plotted it, and as the timeline from when she got her cefuroxime and the nearest timeline again, or from when her hemoglobin dropped, this was the only drug that we could confidently say that it was. Ideally, we would have liked to have tested this in vitro with the actual drug, from the actual container, even the packet of the drug that you would test in a lab outside of that, but unfortunately it just wasn't possible as the timing. We couldn't take her back in to receive more blood samples due to COVID. But none of the other medications would have made sense to cause the hemolytic anemia.
And so just being devil's advocate, so what drugs did she receive for her anaesthetic? Because presumably they would be on the same timeline as the initial cefuroxime dose.
Yeah, so she received propofol, rocuronium, fentanyl, and outside of that, just some antiemetics. Right.
And I think you said she previously had cefuroxime for other surgeries.
She did, yeah. So in reading the literature, Garrity seems to be the main guy in the drug-induced immune hemolytic anemia. And in most cases, actually, patients do receive the offending drug 2 or 3 times before an incident of the drug-induced immune hemolytic anemia can take place.
Right. So it's
quite common.
Unlike the normal sort of anaphylaxis where we're spending all our time, or a lot of time at the moment, trying to understand who we cannot describe, this is something that the more often you get it, although
exactly.
It's very yeah.
Interesting.
Great. Thank you very much indeed.
Thank you.
Thank you. The next presentation is Dr. Jackson.
Oh, hi, that's me. Hi.
Hi. Please go ahead when you're...
Oh, great. So I'm Rebecca. I'm one of the anaesthetic regs, and this is a project that we did with one of the surgical regs. And what we did is we looked at the post-operative outcomes of patients who referred for CPEX testing, who then undergo pancreatic surgery. So the background of this project is that all patients in South Wales listed for pancreatic surgery are seen in an anaesthetic pre-assessment clinic. And this is pre-COVID times when we had CPEX testing. Anyone who's deemed to be less fit is then sent for a CPEX test before their surgery. And when I went to these clinics as part of my peri-op module, I was just really interested to find out how these patients did and were their outcomes different from those that we didn't send for CPEX testing. So what we did is we retrospectively reviewed over a 15-month period all patients who underwent pancreatic surgery within our hospital. And we looked at the outcomes. Now, it has to be noted that we included laparoscopic and open procedures and also malignant and non-malignant indications for surgery. And before we go into the results, it's important to note that there was quite discrepancy between the two sample sizes. So actually, we only had 7 patients who had a CPEX test and who then had surgery, compared to 93 patients who had surgery without a CPEX test. Despite this, though, we did find that there was no difference in the length of stay, so whether that was hospital admission or ITU admission, but there was an increased incidence of acute kidney injury in those patients who were sent for CPEX testing, and we did find this to be statistically significant. And we did think that was quite interesting because we do know acute kidney injury does have a clinical impact. It is not a benign condition and is associated with post-operative morbidity. But our feeling in conclusion, our key points, really the important points that we got from this project really focus around the provision of this pre-assessment service. So it's quite unique in our hospital. And it initially was started to improve efficiency, so it was to prevent on-the-day cancellations. But what we found is that having this opportunity to review our patients pre-operatively, we can make a subjective assessment of their fitness, and this does translate into the risk of developing acute kidney injury, potentially from our data that we found. So those that we thought were less fit, who then had a CPEX test, were at higher risk of developing an AKI. And if we can identify these patients early, then we could potentially improve our post-operative morbidity. And I think the main point that we've taken from this, it has shown us there is an unexpected benefit from this clinic that we didn't really appreciate initially. And I think this is especially true now during COVID times, where CPEX testing for us at the moment is still not an option, that this opportunity for anaesthetists to make a subjective assessment of someone's fitness does actually have a tangible clinical relevance in their post-operative course. And if we want to continue to improve our post-operative care, then I think it's vital that we also continue this service. So that's our main points from that. So thank you for listening.
Thank you very much indeed. Really, really interesting. I understand that it's a subjective assessment, but do you have a feel for the sort of questions people ask? Were they ever using something like the Duke activity score, or was it all straightforward history taking?
It was more or less, it wasn't actually a score taking, but it was like, could you walk, did you have to stop when you were walking from the car park to get to clinic? Can you walk up a flight of stairs? So it was trying to put it into a practical sense, and then getting an idea of how fit the person is and how much activity they do. So that was then whether that triggered then a referral or not.
And where, I mean, your comments about the opportunity to have a more in-depth discussion and evaluation are also very intriguing. Of the 93 that didn't have a CPEX test, a significant number still got AKI.
Yeah.
Do you have any feel for whether those were, I mean, it's difficult to know what the CPEX test hasn't necessarily contributed. It's more about the subjective assessment of fitness.
Yeah. That was what I was using it as a kind of, the CPEX referral was a kind of surrogate for your poor fitness. It potentially could have affected the type of surgery that they were having. So a lot of these, because it included all types of surgery, some of them did have major, so a PPPD, or did actually have a longer time in ITU, or did have metastatic disease as well. So I don't know whether that kind of affected your risk of acute kidney injury. So it was because it was such a heterogeneous group of patients that we were looking at. I wasn't sure.
And what are you going to do with once COVID's over, assuming it is at some point in our lives?
Yeah.
What are you going to do with CPEX testing? Do you think that will be part of what you do, or will you go?
So I think from what I've done, I've given it to the lead anaesthetist who does this, and I think this is what he was quite happy to have some data to justify his continuing his clinic, because he has actually continued it during COVID. I think from CPEX testing, what we have at the moment is an issue with capacity. We don't actually have that many anaesthetists to do CPEX testing. There is plans to get more people trained up and also trainees interested. But I think it will continue on this basis of, if they think that you're not as fit, then you'll be referred for CPEX testing. And actually surgeons are very good at identifying patients who are going to be at higher risk as well. So I think it highlights this benefit of having this collaborative approach as well, and having this clinic is an opportunity just to talk to everybody as well, which I think is beneficial.
I guess what it says is the people who look unfit, certainly a number of those are.
Yeah.
Interested, because you had your 12 kidney injuries in the other group.
Yeah.
There may be a bunch of people who look fit who actually aren't, who you're not flagging up because of the lack of testing.
Yeah.
Interesting. Okay. Well, good luck with the service. Thank you very much indeed. The next presentation, if you're not presenting, can I just encourage you to go on mute, please? Next presentation is Dr. Fitzgerald.
Hi there, can you hear me?
Yeah, loud and clear.
Great. So this is a fairly simple audit myself and Dr. Mark Ross did. He's the consultant in charge for this project. And we simply just looked at basically, so in the Royal College of Anaesthetists recommends that all areas where anaesthetics is provided, there should be immediately available emergency guidelines should an emergency take place. So what we did in 2017, before I arrived in this hospital, was they put together a simple ring-bound folder, and they put that in the second drawer of every anaesthetic machine in the hospital, so that if there was an emergency, you could just open the second drawer, grab the folder, and you'd have guidelines immediately available, so you'd know exactly what to do in the situation. And what I did was, just over a day, went to all 22 sites where anaesthesia was provided in Galway University Hospital, and checked, are the folders present? And if they are present, are they complete when compared to the master folder? And unfortunately, what we noticed that only 4 of the 22 folders were complete. 6 places where anesthesia is provided had no folders whatsoever, and the rest were incomplete. And if you look at that table there, what you can see is basically which ones are complete and which ones are incomplete. And that's just the table there on the right. So the intervention we did was quite simple. So a simple ring-bound folder, unfortunately, is very likely to fall apart, and pages are likely to fall out. So what we've done is we've got a laminated spiral-bound book now, which we are now placed in the second drawer of every anaesthetic machine in the hospital. And what we've also done is we have a kind of team app where we do our rostering and things like that. And in that team app as well, we have an emergency guidelines section. So provided you have a phone with an internet connection, you can also immediately access this. And the idea is that in any emergency in the hospital, they tend to be fairly high stress situations, and just having emergency guidelines immediately at hand has been shown to improve outcomes. And the fact that they weren't there wasn't good enough. So now we're making sure that what is available is more durable and of better quality than what was there previously. And if it's not there, you can also get it somewhere else rapidly. And that's kind of the long and the short of it, really.
Great, thank you very much. Can I ask what precipitated the audit? Was it the observation that you couldn't find a folder, or?
Yeah, it was exactly that. So we were kind of going through, and at one time, just one of the consultants noticed that, I don't even think, it wasn't in an emergency situation, just noticed that the folder was missing. And so we just went through all the anaesthetic workplaces we could find, and we kind of had this litmus test of basically that if you couldn't find it within 5 minutes, it wasn't available, because in a true high stress situation, you're not going to be scrambling around looking for a folder for more than that. And to be honest, what was shocking as well was in areas where anesthesia isn't routinely provided, such as our brachytherapy suite, our kind of catheterization suite, interventional radiology. A lot of the nursing staff there and a lot of the doctors there who weren't anesthetic trainees had no idea that such a folder even existed. So what we also plan to do is present this internally at a trainee audit day, let everyone know about the presence of the folder, where it is, and where you can get it should you need it.
Brilliant. And I guess now it's a bit far ahead, but the folders were originally introduced in 2017, so that your attrition rate is over 3 years. I guess you need to go back in 2023 and do the same thing all over again.
Yeah, that's the plan. Well, we're hoping. So they're currently being made up, but basically what you'll have is, you probably remember having a thesis bound at some point where it's this kind of laminated, spiral-bound, hard copy book. We've kind of replaced those kind of ring-bound folders with that, and the idea is that they're not just going to fall apart over time like the old folders did.
Could you add the presence of the folder to your anaesthetic checklist for each anaesthetic machine?
I hadn't thought about that, but that seems like a thing that would be definitely worth doing, and I think I will definitely say it to the consultants and see if we can do that.
Okay, and the other thing that intrigues me is have you created the electronic version? Because I'd be really interested to get a feel for how many people would choose to use the app or go to the app as first choice, and how many would go to the folder.
So the app has it's just a team app. It's basically our rostering app, and then it has exactly the same guidelines in a section of the folder that says anaesthetic emergencies. And all of our trainees were told about where that was on our very first day. So who would have preference over which one, I don't know. But I think and honestly, I know personally, I would rather have the hardbound one, because I wouldn't want to be fiddling around with an app that may take 20 minutes to load.
Yeah, I understood that. I'd be interested to see an audit divided by age as to who uses the app and who doesn't. Any questions from others on the call about this presentation? Great. Well, thank you very much, Dr. Fitzgerald.
Thank you.
Ciarán, and yep, thank you very much. Next presentation is Dr. Carney. Are you there? I can't see all the names on my screen, so.
Hi there, everyone. So my name is Ciarán. I'm the anaesthetics intern in Cork University Hospital, and the case that I'd like to present to you this morning is that of a complex polytrauma patient who was admitted to the ICU in CUH. Sorry, on my screen is changing. Who was admitted to CUH ICU following a complex polytrauma in which he was a victim of a motorcycle versus car RTA in which the patient was traveling on a motorcycle. He was airlifted to CUH with a number of injuries as listed on the side of the poster there. Sorry, the screen keeps changing to a different poster.
Is this your pet? No, sorry. I'm not sure what's happened there. Give me 1 second.
No. That's mine, yeah.
Sorry about that.
Yeah, so he was admitted with a teardrop C2 fracture, a midline pelvic fracture is demonstrated in figure A, bilateral wrist fractures, L3, 4, and 5 fractures, rib T10 and 12 fractures, and a left tibia and fibula fracture. Initial imaging upon admission was concerning for a filling defect within the descending thoracic aorta, which was possibly consistent with a number of non-occlusive thrombi, such as an intimal tear. So the patient was admitted to ICU in CUH. The reason why we chose to maybe present this case is that there was a number of interesting challenges that co-presented with him. For starters, he was airlifted in the middle of the night to CUH. As per policy for admitting patients to ICU in our hospital, patients need to be COVID swabbed. This meant, as he was not COVID swabbed, despite not having any concern for COVID, he was brought to a satellite ICU, which is physically quite far away from the main theatre block, main ICU, and imaging. This was an issue just for nursing staff. He was also in a Miami J collar and spinal precautions, which required additional staff, again in the middle of the night. And this is probably the first kind of major complex polytrauma that was brought in during COVID times, and this is a real test of this policy. In addition to that, the imaging was initially taken upon admission and was concerning for an injury in the thoracic aorta. And further imaging with ECG-gated CT imaging was required. However, again, as this was the middle of the night and it's a specialized imaging technique, there was only 2 or 3 radiographers available in the hospital to perform this, and they were not currently on site at the time. And possibly the most interesting part of this case is that there were competing surgical needs. So the 2 major injuries that this patient had was the midline pelvic fracture and the descending aortic injury. Which presented a difficulty in this case as they are somewhat antagonistic of each other, and the decision of how to prioritise which surgical intervention should be undertaken first was one that was quite hotly debated amongst the intensivists involved, and including all the surgical teams who were involved with him. The main antagonistic issues here is that the inability to ask for a TVAR to be conducted to repair the thoracic aorta would involve opening the pelvic binder that he was in, and also the issues post-operatively to anticoagulate him, again with the pelvic fracture, the issues and the risks that could pose. The outcome in this case was that repeat CT imaging with gated imaging techniques were used, and it demonstrated 2 intimal tears at the level of T4 and T5 and the levels of T9 and T10. Following extensive input from vascular surgery, orthopedic surgery, and the consultant intensivist involved in this patient's care, the decision was made to proceed to a TVAR, and the pelvic binder was opened for this procedure. He was then readmitted to ICU for judicious anticoagulation and close monitoring, with the pelvic binder still off at this point. And then subsequently the patient was transferred to the ICU in Tala Hospital for definitive management of the pelvic fracture. So the reason we felt this is quite an interesting case because the polytrauma patients have a potential to present with complex or antagonistic needs as I've described. We felt that this case really highlighted the need for the coordinating input that the consultant intensivist had in this, in managing what was to be prioritised first, particularly given that different surgical teams felt obviously their needs were the most important, but it took a person whose role is an overall view of the patient's overall well-being and how best to manage that. So thank you.
Very interesting case, thank you very much. Was the conversations that you're alluding to, did they take place in person at the bedside, or was this a series of telephone conversations that the consultant intensivist was coordinating?
It was kind of it developed over the course of nearly 2 days, so it was a mixture of both in terms of the imaging issues. I suppose when the CT imaging was initially concerning for a filling defect, that should have been a prompt to immediately proceed to ECG gated imaging. That didn't happen. That took a lot of phone calls and toing and froing. The discussions with teams, they took place at bedsides, but it was kind of important that it all came together towards the latter half of the second day of his admission to decide what was going to the first intervention they're taken, and as he had to be transferred to Tala, that did influence the decision as well, because the definitive management of the pelvic fracture wasn't going to take place in Cork. So that led to the decision to go for TVAR.
And in terms of these sort of slightly sensitive issues, but in terms of the interpersonals, obviously for patients who are not sick enough to go to intensive care, the trauma teams are used to coordinating themselves. How I mean, was it overt and explicit that the intensivist was taking a coordinating role, or was it more implicit? You know, what were the interpersonal dynamics like?
It was kind of more of an implicit role, that they were the one who had the overall overview of the patient, that while maybe the vascular surgeon was very concerned about the filling defect, and the orthopedic surgeons were very concerned about the multiple risk fractures, the multiple fractures that he had, and the pelvic fracture, it was the decision of the intensivist to decide, no, while we can't definitively manage the pelvic fracture, we need to manage the thoracic aortic injury first. And kind of that was it was more implicit. I don't want to say like a peacekeeper or a mediator, but that's kind of maybe where the role of the intensivist came in this situation.
It's a familiar story. I work in Southampton, which is a trauma centre, and we're very used to these types of discussions. I don't know if you have anything similar, but we have a morning trauma meeting now on ICU. So just after the main handover, we get the surgeons, the orthopods, and anybody else relevant down to do a face-to-face meeting, which has been hugely useful.
Such a thing doesn't exist in CUH, to the best of my knowledge at the moment, but it probably be worth implementing.
It might be worth thinking about. Thank you very much indeed. And apologies for the disruption to the slide. The next presentation is Dr. Michael. Apologies if I pronounced it wrong.
Good morning. No, that's okay. Aisling O'Maher is my name. I have to apologise. Can you hear me okay? There's probably a bit of an echo in the background.
We can hear you well.
Okay. So this morning, Aisling's my name. I'm an SHO in CUH also, and this morning I'm presenting an unusual case of ethylene glycol toxicity. So I'd like to present the case of a 34-year-old male who had a background of alcohol dependence, who was found unresponsive at home by his mother and was brought to CUH. On arrival, his neurological status showed a GCS of 6, he had pupils of size 4, and he had a history of seizure-like activity en route. His metabolic profile revealed a profound metabolic acidosis. His pH was 6.9, he had a PCO2 of 1.8 and a bicarb of 2.8. His potassium was 7.5. He had an unreadable lactate, and it was measured as over 20 in the point of care measurement, and his calculated anion gap was 51. In terms of his immediate management, RSI was conducted to secure his airway, his hyperkalemia was treated, and a CVC and vas cath were inserted. He has also commenced on IV fluids. His serum blood samples were sent, and of note his lactate came back as 1.83 millimoles. So this was found on his serum measurement, and this was significantly different from that of the point of care value, which was over 20. So the differential at this stage included a postictal state, ethylene glycol, as well as methanol poisoning, as well as cyanide poisoning. Further investigations revealed quite a significant osmolar gap. So his calculated serum osmolarity was 296, and his measured osmolarity was actually 445. So this this revealed a staggering osmolar gap of 149. In terms of his initial management, in the absence of a specific diagnosis, but with high suspicion of toxic alcohol ingestion, he was commenced on CVVH, sodium bicarb infusion, and fomepizole as well was initiated. So this is a competitive inhibitor of alcohol dehydrogenase. So the following morning, his urine was sent for analysis under light microscopy in the search for calcium oxalate crystals, which were indeed found. And this all but confirmed our diagnosis of ethylene glycol consumption. So information from his mother and sister then supported this with more specific findings that 3 empty bottles of perfume were discovered in his bedroom, notably CK1, Joe Malone, lime and basil, as well as Clinique Happy. So over the course of his stay, 2 main kind of issues were established. The first was his neurological status. So he was having intractable seizures despite being on phenytoin and levetiracetam. Silicosumide was introduced as well as thiopentone. He was continuously on a midazolam infusion as well initially. His repeat CT brain was negative for any acute intracranial bleed or infarct, but showed diffuse cerebral edema and features of toxic leukoencephalopathy consistent with ethylene glycol poisoning. The second main issue was his renal function. So he was continued on dialysis. His creatinine had doubled. However, his anion gap and osmolar gap normalized. So the fomepizole was stopped. A week into his stay, he remained intubated and ventilated with a GCS of 3 despite being off sedation. He continued to have seizures, and his EEG showed a severely encephalopathic picture. His MRI brain also showed extensive deep white matter edema, consistent with the picture. From a renal perspective, he remained anuric, with his urea and creatinine continuing to increase. By day 9, he showed the first signs of a neurological improvement. He showed spontaneous flexion of his upper limb and flexion of the lower limb in response to painful stimuli. His renal function, however, remained poor. At the 2-week mark, he had dramatically improved. At this stage, his GCS was 14 out of 15. He was extubated and he began to produce some urine. On day 16, he was discharged from ICU, switched to intermittent hemodialysis, and his renal function continued to improve on the ward. He continued to spend another week on the ward in the hospital. He was seen by the neuro rehab team, who concluded that he had made a remarkable recovery. Finally, from a cognitive perspective, he displayed retrograde amnesia from May until September of this year, but with preserved antegrade memory. And on the 1st of this month, on the 1st of October, he was discharged. And of note, his MMSE was 29 out of 30, and his creatinine was 130. So overall, I find this a fascinating case. I've just started working in the ICU, so it was one of the first cases that came through the door since I started. And I find it interesting because of the initial guarded prognosis that was given both from a neurological and a kind of renal perspective versus the actual outcome. It was also really interesting to have the discrepancy between the ABG on the point of care, or the lactate on the point of care versus the serum lactate. And that was kind of really crucial in the clincher. It was kind of the clincher really in the diagnosis. And then the other thing that came to mind was that, during social restrictions, whether behaviour might change and whether we may see more people using kind of more accessible alcohol in the absence of alcohol or traditional ethanol.
Great, thank you very much. It looks like you're presenting under challenging conditions, so well done.
Thank you. You can see this is actually a stairwell.
Yeah, no, I figured. The anion gap was fairly extraordinarily large. Do you know the volume of perfume consumed?
The volume of ethylene consumed, is what he said.
I'm interested. How much? I think a perfume.
Yeah, 3 bottles. Three. I'm not sure what was in the bottles, but 3 bottles of perfume were empty, and they had some quantity in them beforehand. I don't know the exact. I don't think we ever found out how much was consumed. No.
Interestingly, striking anion gap from what one typically thinks of perfume bottles as being quite small. That's a very dramatic effect.
Yeah.
Brilliant. Okay, thank you very much indeed.
Thanks.
Thank you. Next presentation is Dr. Free again. You still with us?
Yeah, can you hear me?
Yep. Please go ahead.
Perfect. So again, this is the follow-up to the first part of the audit we did. So again, as I said, a large portion of patients are getting elective surgery or undergoing a barrage of investigations, no indications being made, but and follow-up is tenuous at best for most of them. So we looked at the investigations performed prior to surgery and their impact on management in our hospital. Again, compared to the NICE guidelines. As I said, we retrospectively studied and investigated a current process for booking investigations. We analysed the electronic records to ascertain the ASA status of patients, as well as the surgical graded procedure. We looked at the pre-op investigations to examine what were the indications and follow up on what were the results of those investigations. We compared this then to the NICE guidelines then to calculate the amount of unnecessary investigations that we're doing. And then we used the figures that were retrieved from the finance department of our hospital to calculate a figure for the actual cost of the procedure. So we took a period of 1 week. We selected a total of 103 patients who were undergoing elective surgery in this time frame. In this cohort of patients, a total of 348 investigations were carried out, and 259 or 74% of these investigations were deemed to be unnecessary or not required as per the NICE guidelines. We examined the 259 unnecessary investigations and looked at the results. And we ascertained that none of these results altered the management of the patients throughout the perioperative period. As can be seen from the chart here, that a large number of these investigations were bloods, coags, ECGs, and chest x-rays. UNEs counted for 66% of patients who had a UNE done, wasn't required, as well 59% of coags, 48% of ECGs, and 47% of chest x-rays. The audit revealed that there's a serious issue with overuse of preoperative blood tests, chest x-rays, and ECGs. Instead of tailoring our preoperative investigations to fit each patient, our current approach is to use a blunderbuss approach on all patients in hopes it will identify a relevant issue. As I said, their use of rainbow testing, as I previously alluded to, may increase the risk of having missed identical findings, as has been proven in many cases. But this could potentially be improved the implementation of single site-based guidelines. And this could lead, as our calculations, this could lead to a decrease in the financial burden on the HC with a maximum possible saving of over 250,000 in 1 year and significantly reduced potential harm to patients. We also have to characterize that there may be a reduced, couldn't calculate the effect of delays in procedures as well, getting these investigations, which has also hampered our procedures. So we're currently looking at introducing, hopefully, ideally an electronic version of these guidelines. So instead of having patients, interns booking things, it will be automatically booked for them as they come to the hospital based on their medications that they're on, based on the surgery they're having, and based on the indications and medical history that the patients have, which are all going to be recorded on our electronic system. So that's our ultimate goal in the end game. So thanks very much for that.
Thanks very much. Really interesting follow-up on the previous poster. So it's an extraordinary amount of money pending your automatic system, as I understand your proposal at the end. So having the tests specified by the system. Have you considered investing in a person or even a part of a person to save you this sort of money going forward? Because it would, weekly review of what the sort of testing that's been done and feedback on the number of patients you're talking about wouldn't take that much time and would seemingly generate an enormous financial surplus.
So that's what I said, we're in discussion now with the finance department regarding that to try and get this system ideally paid for, but as I said, it's hard for such a big hospital to get, I suppose, every department on board with booking the exact investigations that are required. And I suppose we had the teaching sessions, as I said, multiple teaching sessions with the guys to try to discover the best way of doing it. However, I suppose it will just take time for it to be implemented more so than anything like that.
And can I ask how early before surgery are people making the decisions? Are the surgeons making these requests for tests? Is it immediately before, or is it several weeks before?
So according to the interns that we were discussing with, patients generally come either the night before the surgery and they're getting the investigations booked and done that night by the interns on call, or essentially they're getting these investigations booked in a kind of bulk. So essentially they're getting a form with about 20 procedures that are going to be placed in a week, and they're going to be booking all of the investigations at the same time. So again, they're just kind of booking them as analysing the charts, but more so booking them as everyone's getting a chest x-ray coming to theatre, everyone's getting an ECG.
Goodness. Because I mean, if there was a lead time, if the decisions were being made earlier and somebody could select the tests maybe a week out, it would be possible then to review, for an anaesthetist, for example, to review the set of tests and say, we really don't need this, 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 and this.
Exactly, okay. That's the ultimate goal, is to try avoid getting those investigations. And again, as I said, there has been cases in, I think one in England there, Mr. Yu, who's a gentleman came in for an inguinal hernia repair, had a chest x-ray, and chest x-ray was never identified, no indication for it, and identified a well-circumscribed mass. And then 9 years later, he represented and had a small cell cancer of the lung, and eventually took not only the doctor who ordered the investigation, but also the team, as well as the doctor who discharged the patient. As there was kind of multiple scenarios where they failed to follow up on the actual investigation results.
Yeah, that's food for thought. Thank you very much indeed.
Thanks very much for that.
Next presentation, Dr. Healy.
Morning, my name is Claire Healy. I'm an anaesthetics SHO working in Cork University Hospital, and I'm going to present the findings of an audit that I did with Dr. Aoife O'Loughlin and Dr. Dan Milan on the equipment knowledge of beginner anaesthesiologists in our hospital. So as I'm sure we're all very aware, anaesthesiology is very complex and makes use of knowledge and equipment that you may not have encountered in other specialties. And beginning a career in anaesthesiology can be quite daunting for a multitude of reasons, including the introduction of this wide variety of equipment. So the purpose of this audit was to assess the knowledge of the most junior anaesthesiologists in Cork University Hospital at the very beginning of their training. So in July this year, we had 10 beginners starting in our department, and of those 10, they were asked to anonymously complete a paper survey during their first month of work. They were asked the duration of their previous anaesthesia experience and were provided with pictures of 5 different pieces of equipment. And they were asked to name the piece of equipment, state its use, state any contraindications that they knew of, and report if they would feel comfortable setting up or using this piece of equipment independently. So 8 of the 10 participants responded, and 50% of those had 3 months or less experience. So they tended to have done the intern job in their previous years, and 4 had no previous experience. With the equipment that we've showed, we tried to give a range, kind of more frequently used things, and then 1 or 2 that they may not have encountered as readily. And so we included, they were all able to successfully name, give uses of and contraindications to the use of a Macintosh laryngoscope, the fluid warmer that is used in CUH, a neuromuscular monitor, and the arterial line. 7 of the 8 said they would be comfortable using these pieces of equipment independently. However, only 3, so 37.5%, could successfully identify the rapid transducer and its use. And this was kind of the more difficult piece of equipment that we included, just to see if they had any knowledge of it. None of the respondents felt that they would be comfortable setting up this piece of equipment and using it independently. We're hoping to repeat this audit with different pieces of equipment this month. So the beginners had started call about 6 weeks ago. So they've kind of had 3 months of experience now, and they've done a bit of theatre calls, so that they may have encountered more of the unusual pieces of equipment more readily. So I suppose equipment just adds an extra layer of complexity to the specialty, and early exposure and if possible teaching sessions about frequently used equipment is vital. In CUH, all of the beginners for their first couple of weeks are given dedicated teaching sessions just to help them get their heads around the specialty and teach them about kind of general topics that are important within the specialty, but there isn't any that specify solely just on equipment, and the equipment that we use in theatre, they tend to pick it up during their working day in theatre, dependent on who they're working with and what kind of cases they're doing on the day. Knowledge of the equipment and its use is imperative to ensure safe practice and patient safety, especially with the pieces of equipment that are less frequently used and that are likely to be used in an emergency setting. Thank you.
Great, thank you very much. So can I add the rapid transfuser, is that something that you would have available in every theatre, or is that something that's maybe one per
We have
theatre?
available on our theatre corridor. So within the theatre complex, there's about 12 theatres in one place, and we have 1 or else 2 rapid transfusers available for emergency AAAs and things like that. As I said, most of them hadn't encountered it because they hadn't done cases that would have required it. But it is something that I know when I started, I was sent to go get and hadn't a clue what I was looking for, and I just thought it was an important one to be aware of.
Yeah, and whereas I guess the other 4 items would be in each theatre and would be used on a pretty regular basis. And,
yeah, absolutely.
Have you made any efforts to think through what other things apart from the rapid transfuser would fall into the less obvious box? Because you'd be pretty disappointed if they didn't recognise a laryngoscope. But equally, how long is the list of the less commonly used pieces of kit that you should be teaching?
Well, I suppose what we were thinking for the next bit is that we might so we have dedicated packs for insertion of things like VASCATs and central lines and things like that, and that unless they have been using, they may again not be familiar with them, but may be required to attempt to use them late at night or during emergency cases. So we were thinking that we'll probably show them the constituent parts of these packs so that they're aware of what the pieces of equipment required are for those, for the insertion of these kind of lines and things like that.
Yeah, and I guess some of the less commonly used monitors, that, things like cardiac output monitors and awareness monitors, are they on a theatre basis or on a theatre suite basis?
They're on on a theatre basis, but they're not necessarily used on a daily basis. So it is that is something that's on our list as well to potentially include. It depends on who they've worked with, whether or not they've seen and what cases they've done, whether they've seen some of these things. Because I suppose every specialist has their own kind of preferred equipment that they like to use in monitoring, that they might additionally use for their patients.
Of course. Any questions from others on the call about this presentation? Brilliant. Thank you very much indeed.
Thank you.
And Dr. Fitzgerald.
Hey again.
Hello again.
So this is another quick audit I did with Dr. Ross and then another SHO by the name of Owen Farrell. And basically, when I started, I noticed that that on all of the stickers that we put on the syringes that contain our medicines that we give intravenously, there's a little line to put in the dose per mil. And I noticed that not a single person was doing that. So I thought it must be there for a reason. So I went and looked at a paper written by the British Journal of Anaesthesia, where they published guidance on medication safety in the operating room. And what they said was that every drug that's given intravenously to a patient should have the medicine that's written on every syringe, should have the medicine that's in the syringe, the dose per mil, and the date that it was prepared, documented on the syringe. And this just wasn't being done. So what myself and the SHO did was we prospectively just observed consultants, regs, and other SHOs preparing these drugs in theatres and seeing what was labelled, what was documented, and what was given. And basically what we found was not shocking, not surprising, but kind of not in keeping with practice. So we found that propofol, so we don't use etomidate in Ireland, so our only real induction agent would be propofol or thiopentone sodium. So propofol, being a white liquid, was never once labelled. In 50 cases, no one ever, although propofol was used in every case, we never used propofol. And on Dansitron and dexamethasone, the antiemetics were only intermittently labelled. The rest of the drugs all had their labels on them, but rarely ever had their dose written on per mil, written on the syringe. So only the kind of provider prepared drugs, in particular remifentanil, morphine or oxycodone, and midazolam, ever had their dose written on per mil. And not once on any syringe did we ever notice that anybody had written the date of preparation on the syringe either. Now, if you look at our kind of colleagues on the ward, especially nursing staff, you'll see that anything they give is very clearly documented. So this is a kind of problem on our end regarding to what we're giving intravenously and what we're not doing. It's important because basically medication errors are the most common cause of drug error, of hospital errors. And there's about, for every 100 patients who comes into for a hospital for a surgery, about 5 of them will experience a medication error. And between 0.35 and 0.75% of anesthetics given will have a definite medication error. Now, in our audit, we had no medication errors and we had no adverse outcomes. And our understanding is probably that there's a kind of shared knowledge amongst all anesthesiologists that you kind of know what's in a syringe as long as it's labeled, because you don't, because of manufacturers would make it the same with the preparation. So we use one brand. That's another audit. Another one of the SHOs are doing that I helped with, where we looked at basically that we're using the same brands all the time. They're always using the same, and the same brands are always being prepared, are always from the factory to the same concentration per milliliter. So everyone kind of knows what's in a syringe just by looking at it, but still the guidelines are very clear, and we're not kind of keeping up with those. So once again, we intend to present this at our kind of internal audit trainee day, and then re-audit about 6 months once we've got that done. But basically, yeah, we're not keeping up with adequate labeling. This is an important thing that I think we should be doing.
Great, thank you. Very, very interesting audit. I guess it's one of those, it's a small incremental cost to do the labeling for, but an important one for a rare avoidance, although you didn't get any adverse events, you know, every now and then they do happen. And particularly medico-legally, you've got nowhere to go if the syringe wasn't labeled and you give the wrong drug.
Yeah.
How much, so of the drugs that are intermittently labeled, are they a completely standard dose, or are they in your hospital, are they drugs that are being diluted?
Yeah, so what we noticed was that the only drugs that people ever wrote the dose per milliliter on were drugs that were diluted, in particular the morphine, in particular midazolam and remifentanil, because it comes in the powder form. The rest of the drugs all came in, were never diluted, so they came in a standard concentration. So everyone knew instinctively what was the dose per milliliter. The only discrepancy between the actual vials was that we have 2 brands of ondansetron that we use in the hospital. One of them comes in 8 milligrams at 2 milligrams per mil. and one of them is a 4 milligram vial, but they're both 2 milligrams per mil. So if you pick up a syringe with 4 mils in it, you know there's 8 milligrams in it. If you pick up a syringe with 2 mils in it, you know there's 4 milligrams in it. And that was kind of what I was saying about this kind of shared knowledge that everyone in the hospital has exactly how much is in a syringe, just by how much is in it, provided it's labeled.
Interesting. And is there any move in your hospital to move to pre-filled syringes, or?
Yeah. So ephedrine, atropine, and phenylephrine are typically used in pre-filled syringes in our hospital. So at the top of every anaesthetic machine, we have a box of the pre-filled syringes. I know there's also some hospitals use a lot of pre-filled succinylcholine. I was thinking about what I would do in an ideal world. Should I do this product again? Would be I would talk directly to the label makers, and so I actually have some of the labels here. You can see that there. I just replaced it so that it actually says the manufacturer made dose per mil. So so it kind of removes that extra step of a human interaction where I think it's just people not doing it because it's an extra bit of work. If we can remove that, it'll be easier. So, for example, metaraminol, the sticker brand we use, is labeled at 0.5 milligrams per mil. Everybody makes it up to that concentration because it's already pre-labeled to that, and nobody has any, and then it's all there already.
Brilliant. Okay, thank you very much.